obstructive sleep apnea, and resistant hypertension or difficult to treat hypertension, as Dr. Osama talked before. Why we are talking this topic? We are talking this topic because of two important aims. The first one is this topic, obstructive sleep apnea, is underestimated. It is underestimated from the culture and maybe from the doctor themselves, from our perspective. Secondly, which is related to our topic and our talk about today, which is hypertension, obstructive sleep apnea is one of the most important causes of hypertension or cofactor for the predisposition of hypertension. So what is obstructive sleep apnea? Obstructive sleep apnea is the recurrent, partial or complete obstruction of the upper airways. Usually, the event lasts for more than 10 seconds and associated with desaturation, which is decrement in oxygen level for 3 to 4% or more, plus an arousal. These events occur usually periodically throughout the night. And if there is complete cessation of breathing, this is apnea. And if there is partial cessation of breathing with desaturation, it is called hypopnea. And the sum or the average of the apnea-hypopnea index is considered as a degree for assessment of the severity of OSA. And what is resistant hypertension? Resistant hypertension or difficult to treat hypertension by definition is the use of 3 antihypertensive drugs and life modification methods to control blood pressure, but we can't. What happens in OSA or in obstructive sleep apnea? What happens is that the pharyngeal muscles, the muscles that support the tongue, the soft palate, all are being relaxed throughout sleep in some people. And when they relax, soft palate will drop down, pharyngeal muscles will approximate, and the tongue may return back. All of them are going to occlude the upper airway. This event will result in cessation of breathing and reduction in oxygen level. The brain will detect this desaturation and produce an arousal to return back the muscle stretch again and opening of the airway once again. And when the patient deepens again into sleep, the whole story will return back. There will be relaxation, occlusion of the upper airway, desaturation, and another arousal. And these events happens periodically throughout the night. How prevalent is the OSA? Actually, as we said, OSA is too much underestimated. It seems that OSA has been ascertained to affect 24 to 26% of men and 17 to 28% of women. Hypertension is also a highly prevalent disease, as we all talk about. The prevalence of hypertension in OSA patients is estimated to be 30 to 70%. Patients with severe OSA, the prevalence of hypertension is higher, 53%, as compared to those with moderate OSA, 46%. And OSA was found to have the greatest association with difficult to treat hypertension, 64%, rather than primary hyperaldosteronism. What is the pathophysiology or why obstructive sleep apnea causes hypertension? The answer is a little bit complex and multifactorial. In patients with OSA, there is increase in the sympathetic tone with repeated apneic episodes. There is hypoxemia that are being detected by the carotid body chemoreceptors, and this will stimulate the sympathetic tone in the cardiorespiratory events. at the cardiorespiratory center, which stimulates the heart to pump harder, to pump in a higher rate, also induce vasoconstriction, all of which precipitate to hypertension. Also, there is some injury to the endothelial layer of the blood vessels with repeated hypoxemia. With repeated hypoxemia and the repeated hypoxemia and reoxygenation, there is oxidative stress and relief of oxidative materials such as cytokines, inflammatory mediators that lead to inflammation and damage to the endothelium and render them liable for sticking with the bad cholesterol and precipitate for atherosclerosis. Also, we said that there is peripheral vasoconstriction that occurs in OSA, and there is activation of the renin-angiotensin-aldosterone system.
Only 5 minutes.
Okay. Also, there is altered baroreceptor activity. So there is multifactorial effects in the precipitation of hypertension in OSA patients. What is important is how can we consider the patient has OSA or not, the clinical presentation of OSA. We have to take in our minds the important presentation that could present with OSA patients. Usually, from the first sight, obesity is a major contributing factor to OSA. Also, there is, when examining the upper airway, there is overcrowdedness in the upper airway, which contribute to the OSA. Symptoms also important, such as loud snoring, witnessed apnea, and daytime hypersomnolence, in addition to morning headaches and other symptoms. Usually, when there is a patient suffering from hypertension and he has loud snoring and daytime hypersomnolence, we have to check for the presence or not of OSA. Sometimes we have the complications of OSA, such as dyslipidemia, hyperglycemia. And if we can examine the mouth and we can see the crowdedness in the upper opening, in the opening of the airways, we can estimate the patient may have OSA. So how can we diagnose obstructive sleep apnea? The gold standard method for diagnosis of obstructive sleep apnea
Dr. Ahmed, 2 minutes بعد.
Is polysomnography, which is multi-test in one test, in which we assess breathing, we assess EEG activity, we know the patient is sleeping, awakening, in what sleep stage, and the presence or not of respiratory events, and oxygen level. Polysomnography is the gold standard method of diagnosis. It is through which we can diagnose the condition, and also we can use it to assess the proper settings for PAP therapy for that patient, which cannot be used or gained with home sleep apnea test. Another way to diagnose OSA is the home sleep apnea test, which is simpler, less costly, and easier to be applied and considered as a screening tool for the presence of OSA. In obstructive sleep apnea, we will see the cessation of breathing and desaturation and the associated arousals. Also, the ambulatory blood pressure monitoring can help to diagnose the non-dipping blood pressure that occurs in OSA patients. What are the methods of treatment of OSA? It is a multifactorial. CPAP is considered as a cornerstone to correct the OSA events, and it has been used and seen that it corrects hypertension if respiratory events are being controlled.
Time over.
Lifestyle modification, oral appliances, yes. Upper airway surgery and antihypertensive treatment. This is the oral appliance that can protrude the lower jaw and open the airways, but it is less effective than PAP therapy. Thank you.
شكرا.